Welcome back, clinical problem solvers, to Rafin Medina subspecialty VMR series. Today, I'm very happy and excited to have Dr. Eli and Dr. Anna, and who'll be a case discussion and case presenter for the Rheumatology VMR. And before introducing themselves to the audience, I would like to thank Vijay, who is making this session happening today. And Vijay, do you want to unmute yourself and say introduce yourself to the audience?
Hello everyone, this is Vijay from India. I'm one of the CP Solvers member. Excited to hear the case.
Thank you, Vijay. And we have another fantastic academy member, Lira. She's gonna do the teaching points. Lira, do you want to unmute yourself and introduce yourself?
Yeah, sure. Hi, everyone. My name is Lara, and I'm a final year medical student from Russia. Very excited for today's session.
Thank you so much, Lira, for doing the teaching points today. And those who all don't know me, I'm Rahul. I'm from India. I'm an incoming PGY1 at the Yale Waterbury Hospital, Connecticut, and I matured recently. And And before handing over the mic to the Dr. Eli and Dr. Anna, I would like to introduce themselves to the audience. Dr. Eli is a rheumatologist and associate professor of medicine at the Massachusetts General Hospital and Harvard Medical School. Dr. Eli's career has been focused on internal medicine education across all stages of training. He serves as a curriculum phase director at Harvard Medical School and firm chief in the MGH Internal Medicine Residency Program and an associate program director in the MGH Rheumatology Fellowship. And he also leads the MGH Clinician Educator track for the Department of Medicine Subspecialty Fellows. Dr. Eli, it's our pleasure and honor to have you here. And if you don't mind, can you unmute yourself and introduce yourself to the audience?
Thanks so much, Rahul. I'm really pleased to be here. First of all, congrats on such an amazing endeavor in clinical problem solvers. I think it's just amazing how you all go about teaching the clinical problem solving skills that I think are one of the things I love most about medicine and rheumatology specifically. So just really delighted to be here to kind of share in this project.
Awesome. Thank you so much. And I just have a few questions for you. And what made you to choose, rheumatology, and what inspired you to take care of all the autoimmune patients?
Yeah, it was a really roundabout path for me. I thought I wanted to be an emergency medicine physician. And then when I came to internal medicine, I was pretty sure I was going to do pulmonary critical care. And kind of late in residency, I found rheumatology. I think for some of us, the path is really straightforward. And for some of us, it's a really winding path. And I think for me, I'm just very thankful that I was able to kind of pivot and keep my options open because I, really love rheumatology as a field. But when I think back about what were kind of the key things that changed my career path, I would say it was a couple of things. I would love to hear from Anna how her decision process was same or different. But I think I was always someone that really loved learning about all of the organ systems, and I really loved internal medicine as a whole. And while rheumatology is not the only subspecialty that is a really general one, it is definitely one of the few where you really have to know and understand all of the organ systems, and the learning and just like the clinical variety remains really, really broad throughout my career. So I've been an attending now for about 10 years, and every clinic is still a challenge, and I'm learning all the time because medicine is humbling in general, but rheumatology is a very humbling specialty. The other thing is I really wanted a longitudinal relationship with patients, and that is something that I, probably love the most today. And it's just amazing to have the opportunity to really walk someone's path with them from being really sick to getting really well and seeing people get back to, a much better stage of life. And when that doesn't happen, to kind of really be able to be there to support them. And then finally, I would say is we have great medicines in rheumatology, and that's different now than it was 10 years ago. And maybe this is an overstatement, but I feel like anyone who walks into a rheumatologist's office can feel better because we have a lot of things to offer them. And as I'm saying this, I'm thinking, well, why isn't everyone going into rheumatology? And I understand that it's it's not a specialty for everyone, but I do think that rheumatology in particular suffers from this problem of being a little bit mysterious. Not as much time is spent on it in certain aspects of the medical school curriculum, and there's not that much exposure to rheumatology unless you get lucky like I did during residency or you seek it out specifically. So I think we're really happy to be here to try to help people think more about rheumatology, whether they choose the field or are seeing rheumatic disease in their other fields that they're working in.
Thank you so much for the inspiring journey. And now I really want to introduce Dr. Anna Valle, who is our case presenter today. She is a rheumatology fellow at Brigham's and Women's Hospital. She attended Johns Hopkins University and Johns Hopkins Bloomberg School of Medicine, where she studied public health during her undergraduate and graduate years. Afterwards, she worked as a research coordinator, which introduced her to the field of rheumatology and instilled a passion for clinical research. She obtained a medical degree from Zucker School of Medicine at Hofstra, Northwell, and completed residency at Montefiore Medical Center in the Bronx, New York, and where she was awarded Intern of the Year and Ambulatory Chief. She is pursuing a clinical research career where she dedicates her time to address health inequities within the rheumatology and further understand idiopathic inflammatory myopathies. In her free time, she enjoys bar, podcast, and spending time with the two cats, Dolly and Steve. Welcome, Dr. Anna. It's our pleasure to have you today.
Thank you so much for having me. I'm very excited to be here. I'm a large clinical problem solver fan.
Awesome. So what do you do outside of medicine, Dr. Anna?
So I do like to travel a little bit, and we're hopefully going to Spain in a few months, and recently came back from Arizona where I was in Sedona with some of my close friends, and also like to run a little bit and be physically active when the weather allows. Can't say I keep it up during winter as much, and I love to read a good nonfiction or fiction book that is not related to medicine.
Awesome. You have diverse hobbies. It's
Yes.
fantastic. And I hope you have a great time in Spain soon.
Thank you. Thank you.
Yeah. So Vijay, if you're ready and you can share your screen and let's get started.
Maybe I'll just say one thing, not as a spoiler alert, but Anna and I do know each other not only because we are in sort of sister hospitals, but Anna and I are part of kind of a project group together that really aims to increase the workforce diversity in our field. I think rheumatology is a field that really affects people of color disproportionately, and our workforce is not nearly as diverse as it could be to really deliver optimal patient care. So we're trying to work on this issue. So for anyone that's interested in that, we're kind of happy to share some of that as well.
Incredible. Thank you so
Yeah,
much.
exactly. I can provide a little bit more additional information later on. The project we're on is called the Academy for Workforce Advancement to Enrich Rheumatology Diversity. And we're basically trying to, through different pillars of leadership, a pipeline, and mentorship and sponsorship, we are trying to increase the representation of those underrepresented in medicine and rheumatology. And so I can provide more information regarding that offline, but that is also one of the reasons I was interested in rheumatology because I come from a long line of strong Latina women, and I saw many patients that reminded me of my family and friends, and these diseases would just take just knock their plans off kilter, all of their hopes and dreams. And now we have medications that help address these rheumatic conditions, but there's still barriers, and on an area level, on an individual level, to ensure that these patients get the right access, the right specialists, the right medications in a timely manner.
That's incredible, Dr. Anna. And thank you so much for advocating for all the patients and especially the medications and everything. Incredible. So happy to have you today. Yeah, let's get started. And Dr. Anna, you can share your first daily quote.
Hey, I have a patient. Her name is Donna. She is a 58-year-old female with a history of Graves' disease, now post-ablation hypothyroidism, and she was referred to rheumatology clinic by her primary care physician due to 2 months of joint pain.
Dr. Anna, do you want to stop here?
I can keep going into the HPI. So over the last 2 months, she seems to have episodes of joint pain, which predominantly affect her left hand and her left wrist. She cannot identify a trigger, but it seems like the pain starts spontaneously. And then she has noticed that when her hands hurt, they also seem swollen and they feel warm to the touch. The pain in her left hand and wrist is worse in the morning. It takes her about 90 minutes until she can begin to use her hand for things like getting dressed, brushing her teeth. And she has been taking Tylenol and ibuprofen due to the joint pain on almost a daily basis. And the ibuprofen seems to make the most difference. But when she stops taking it for more than a day, that pain and swelling and warmth in her left hand quickly come back. She's also noticed that sometimes when she's typing on her keyboard at work, her left pinky, her fifth digit, and her thumb in her left hand can become stuck, and she has to use her other fingers to move it back. There are no associated skin changes over her hands.
Dr. Anna, is it a good time to stop here?
I think it's a good time to stop here.
Awesome. Thank you so much for sharing the bread and butter case of internal medicine, as Dr. Eli mentioned, as he's interested in the whole part of the medicine. Dr. Eli, I'm just curious to know, whenever as an interns and residents, we are sending patients to the rheumatology clinics or any subspecialty clinics with the history of this joint pain, what are the things we must consider before, and how we should approach the joint pain in general?
Yeah, I mean, I think this is such a great topic to discuss because I remember being, an internal medicine resident and just being really overwhelmed with complaints of joint pain. It was hard to know, what do I really need to know about this, how to do the exam, and what of this would actually be like, what I would do with this information. And I think the other kind of key thing to know is that the history and the exam, I think in medical school, we're taught that that's like 90% of the entire presentation, 90% of making the diagnosis. But sometimes when you're in the hospital, it really seems like the labs and the imaging just really take over. And while that is true for some subsets of disease, joint pain is still probably 90% in the history and the physical, which kind of makes it really fun to be able to go in, take a history, do the exam, and at the end of that process, have a really good sense of what's going on before you even send any studies. So I sort of begin with, what are the big buckets that can cause pain? And usually things come in threes, and it's sort of similar in rheumatology, right? Is it an inflammatory problem? Is it a mechanical problem, which most commonly is osteoarthritis, but other tendinopathies and periarticular problems? Or is it a pain issue like fibromyalgia or a neuropathy? And I think much more important than figuring out what is the actual cause, narrowing it down to one of these three buckets is really the task at hand. And so in order to kind of differentiate it between these three, I sort of focus on a couple of things. First is location, and here it's the small joints, although in an asymmetric manner. I think about duration, and kind of 2 months gets into that kind of more chronic period, as well as the tempo. And here I'm a little bit uncertain if it's discrete episodes or that it's more of a chronic pain that's sort of intermittently treated with NSAIDs. It's feeling to me like it's maybe more of the latter, that it's more of a chronic process that just has like a waxing and waning process. But when you're thinking about crystal arthropathy, like gout or pseudo-gout, a key tip-off is sometimes that acute episode and then complete resolution with no symptoms at all between episodes. That doesn't seem like what's happening here, but maybe we'll have a little bit more kind of certainty that we're understanding that his history correctly. Then I think about inflammatory features, and Dr. Valle brought up the prominent morning stiffness lasting more than a half an hour, 90 minutes in this case, the subjective swelling, which is helpful, particularly if pictures are present, because swelling can come and go. And then I think about any associated symptoms, which we haven't heard any about yet, but there are definitely appropriate questions in the chat that might help it. But when you kind of think about what we've heard so far and the three buckets, it's sounding very inflammatory in each of these descriptions, and not because we're in like a rheumatology clinical problem solver sessions, but you have kind of onset of multiple areas in the hand. There's no trauma, there's no neuropathic features, there was swelling and prominent morning stiffness, and that's all raising a pretty high suspicion for an inflammatory joint process.
Awesome. Thank you so much, Dr. Eli, for sharing the clinical approach to the joint pain. I have one question here. Does the past medical history of Graves' disease, which is also autoimmune condition, increases? Is it giving you any clue to think of any other differentials right now in the diagnostic process?
Yeah, Rahul, that's a great question. And while it's true that patients with an autoimmune disease may be more predisposed to another autoimmune disease, the overall effect size in terms of relative risk for kind of a specific problem is relatively low. So while it might increase suspicion a little bit, in the case like this, its presence or its absence really doesn't change the pretest probability dramatically. Although there are some conditions like monogenic disorders, like disorders of connective tissue, such as Ehlers-Danlos and Marfan's, and maybe even to some extent, psoriasis, where the family history has a bigger effect.
Thank you so much, Dr. Eli, for sharing the very practical approach in the association of one autoimmune condition increase the propensity of other autoimmune. Yeah. So Dr. Eli, over to you. So do you want to share your next study quote?
Certainly. Starting with the review of systems, during the same time, she also noted a significantly dry mouth, which seemed to start out of the blue, and it's getting worse to the point that she has to carry water with her at all times, and she needs water in order to eat a meal. She has had 6 cavities in the last 2 years, and it has led to multiple teeth being removed. She has also developed dry eyes, which her ophthalmologist noted in her most recent visit and gave her some over-the-counter lubricating eye drops, which she has used more than 4 times per day. And so, excuse me, I will, this is the beginning of the review of system. I'll take a break here for us to dive a little bit further into the review of system discussion, but there will be additional review of systems shortly.
Sure. Thank you, Dr. Anna. So, Dr. Eli, so now we have entirely different presentation review system with dry mouth requiring multiple, with complicated by dental infection. Back in our medical school, whenever we hear of dry mouth, our reflex diagnosis is Sjogren's syndrome. And now I'm just curious to know, now we're dealing with a joint pain processes, and I really don't know the focality, what's going on with this patient, where exactly is the lesion. And now how could you able to correlate the dry mouth and other symptoms with the ongoing joint pain? Is it something related to the disease process? Is there any two isolated different processes going on, and which is confusing us? And yeah, so what is your practical approach in real time?
Yeah, I think that is great framing. There are kind of so many thoughts that come when you're putting together two symptoms and how related are they. And I think this particular combination brings up several like frameworks that can be really useful in rheumatology. I think one framework I often think about is kind of the big three categories that encompass the vast majority, albeit not 100% of rheumatic diseases. And that is inflammatory arthritis. The most common example of that would be rheumatoid arthritis, but spondyloarthropathies, crystalline arthropathies live in that category. And patients with those conditions usually, although not always, present with joint pain as the sole manifestation, although there are obviously systemic features of those conditions as well. And I will say that Sicca syndrome, which is dry eyes and dry mouth, can certainly be seen in rheumatoid arthritis itself. But there's the inflammatory arthritis condition, inflammatory arthritis bucket. Then the middle bucket is connective tissue diseases. I must say, I do not love that term. I find it confusing because conditions of connective tissue like Ehlers-Danlos and Marfan's are the true connective tissue diseases. But when we use the term connective tissue diseases in rheumatology, we generally mean the ANA positive diseases like lupus, Sjogren's, scleroderma, and myositis, which has been kind of already postulated. This category has been postulated here. And the presence of Sicca symptoms makes that category more possible. Does not rule it in by any means, but it makes it possible. And then I think people are appropriately focusing on Sjogren's as a possibility. And then the third category is vasculitis. And we think about it in terms of vessel size, large vessel, medium vessel, and small vessel. There's nothing vasculitic about this case yet. But I think categorizing your patient into whether they're in one of these buckets or maybe potentially in two of these buckets is a really important first step, because each bucket comes with its own initial laboratory workup. Right. So in this case, inflammatory arthritis, that first aliquot, we were just in the inflammatory arthritis category. Now with the Sicca symptoms, we need to also be thinking about the possibility of a connective tissue disease. And depending on whether there are kind of other features, we might expand the differential within the bucket, right? But those first three buckets are kind of a key starting point. And then maybe one last thing I'll mention is that, rheumatology is tricky because there are many symptoms, and in some diseases, there are overlapping symptoms. There's some symptoms that are kind of really unique to a specific disease. And it's really important to make a distinction between, is it a symptom that's just common in general? Like, let's say fatigue, right? Is it a symptom that might make you more suspicious of a rheumatic condition, like inflammatory arthritis or Raynaud's, as an example? Or is it a symptom that is so specific that it's pointing you to a specific disease or maybe a group of diseases? For example, like cutaneous lupus, right? That would be a specific example. And I would kind of classify Sicca, especially this kind of sudden onset Sicca, in someone who doesn't seem to be on medications that cause Sicca, like antidepressants or other anticholinergic medications, that this would point you into the kind of into rheumatic disease, but in a non-specific way, because many of our conditions can cause Sicca as part of the symptoms. So it's sort of somewhat specific to our field, maybe a little bit more towards the connective tissue diseases, but not enough to say confidently that this is going to be a case of Sjogren's, especially without knowing what other symptoms might be present.
Loved it. I mean, I really loved the three buckets of inflammatory with connective tissues and and vasculitis. And something which is new for me is and we are only going to call as a connective tissue if ANA is positive. And yeah, I really love that pearl. And over to you, Dr. Anna.
Okay, so I will be adding a little bit more to the third bucket. So during this time, she also noted a new rash over her left anterior shin. She describes the rash as multiple red dots the size of a freckle on the front of her left shin. The rash it's not itchy, it's not bumpy, it's flush with her skin. Other than the aesthetics on what the rash looks like, it doesn't bother her. But she does notice it seems to occur in an episodic manner where the rash will be present. It'll be there for about 7 to 10 days, and then it will go away for a few weeks, and then it seems to come back once again for close to 2 weeks in time. Additional review of systems, and I'll just go through these a little bit more quickly, include significant fatigue, which also felt episodic, and her left ring finger fingertip has begun to change color in the cold. It starts off white, it's quite painful, then becomes blue, and finally red as she warms back up. And this is a new finding for over the last 2 years. And she's also had some weight loss. It was partially intentional because she started a gluten-free diet, but she did not expect to lose 30 pounds from switching her diet over. So she is concerned that she has lost more weight than expected. And the rest of the review of systems is negative.
Thank you for sharing all the information. So Dr. Elaine, now how you are going to change your needle now? Now we have the Zika syndrome and the joint pain, and now we have new complaint of skin disease. I mean the skin rash with ongoing Raynaud's phenomenon, which has been going on for the past 2 years, I guess. Is it a 2 years or 2 months, Dr. Anna? Can you please confirm with us?
So the rash was over 2 months. The Raynaud's was over 2 years.
Awesome. Now, how you're going to fit all this together to make the differentials, and yeah, how you're going to change your diagnostic process right now?
Yeah. So I think there's kind of a lot to digest here. Maybe I'll comment on each of these specific review of systems because each one kind of comes with, a teaching point. And maybe we could start with Raynaud's. So it's only one digit that is involved, but I think everyone recognized the fact that there is kind of demarcated, sharp color change with exposure to the cold in the distal digits, whether it's one digit or all digits. That is really typical of Raynaud's. And if this was a 20-year-old woman and did not have any other symptoms and she was developing symptoms like this, I would be really reassured, and I would say that this is most likely primary Raynaud's, which happens in a large percentage of young people, predominantly women, and typically follows a benign course, even though it can be quite bothersome and can be treated if needed. But that would not raise suspicion for a underlying rheumatic disease. But if a 56-year-old woman, like in this case 2 years ago, develops the same exact symptoms, I would be highly concerned that this is secondary Raynaud's. In other words, Raynaud's due to an underlying systemic condition. So I think that seems related. The rash, what they say, a picture is worth 1,000 words. And I can't quite discern from this description whether it is a rash that might be vasculitic, like palpable purpura, which I suppose can come and go, and whether we need to be considering that third category, or whether it is, a rash that might be of a different etiology. But I think as we go back to the 3 categories, we could kind of take stock of where we are. Even though what brought this patient to the doctor was inflammatory arthritis, I think we can be pretty confident that this is not going to be something in the inflammatory arthritis bucket, because those conditions typically do not present much in the way of systemic symptoms. For example, fever would be distinctly unusual. And while this patient doesn't have fever, a 30-pound weight loss is kind of out of proportion what we might expect from those conditions. Those conditions do not present with Raynaud's, and this rash does not seem like it's psoriatic. So I think we can confidently say that we're not going to end up in the inflammatory arthritis bucket. The connective tissue bucket is looking more and more enticing because, like Sika, Raynaud's is a relatively non-specific phenomenon, and it can be seen in any of the connective tissue diseases. And so it doesn't zero us in on a specific disease, but it zeroes us in even more on the category. And then as far as vasculitis, I think we'd have to kind of put that to the side. There's nothing screaming vasculitis right now, but if a dermatologist said that that rash was palpable purpura, or if there was a biopsy with findings of vasculitis on the skin, then I think we need to consider that category a little bit more. And maybe this is a good time to talk a little bit about like our approach to the connective tissue disease category, because I think we all find this category to be really humbling and really challenging. And there's several reasons for that. I think the first reason is that most people with those conditions have multiple symptoms, and physicians, and other providers often have a hard time knowing, is this Occam's razor or Hickham's dictum? In other words, are all of these things related to one single disease, or are they all coming together in an unrelated fashion? Two, there's so many symptoms between all of those that overlap. For example, so just going back to what are the connective tissue diseases? We're talking about lupus, we're talking about Sjogren's, scleroderma, and myositis. And any of those conditions can cause joint pain. Any of those conditions can cause Raynaud's. Any of those conditions can cause dry eyes and dry mouth. And any of those conditions can also cause serositis, which is not present in this case, but pericarditis, pleuritis. Those symptoms are in that bucket of, they might zero you in on the connective tissue diseases, but they don't differentiate between the four. But I would argue with sort of three maybe simple questions, in some cases, you could really narrow down the list of possibilities within the connective tissue diseases. Lupus is totally unpredictable. It can happen with any symptom presenting at any time. And that's why I think when, say, a young woman presents with inflammatory arthritis symptoms with no other systemic features, it's appropriate to check an ANA. Not because the ANA tells you anything about the inflammatory arthritis category, it doesn't, or that it tells you much about the vasculitis category, it doesn't. But it's a very sensitive test for lupus and a somewhat sensitive test for the other connective tissue diseases. So when you're checking an ANA, you're really saying, I want to make sure it's not a connective tissue disease. So lupus can do anything. But Sjogren's, as was already noted, usually, almost always, has Sika as a first or a very early manifestation. So no Sika, you don't really have to worry about Sjogren's. In this case, we obviously have to keep it on the list. Scleroderma follows a similar pattern. The first symptom of scleroderma is almost always Raynaud's. So no Raynaud's, no scleroderma. Unfortunately, this being seemingly a more complex case, which I'm getting a little worried about, you have Raynaud's. So we have to keep scleroderma on the list. And with myositis, you usually have either myositis, skin disease, or interstitial lung disease. I'm not seeing any of that here. So while it's not impossible that this is myositis, I think it'd be kind of unusual. So with Sika, Raynaud's, and myositis, those are kind of the key questions to really narrowing down the list within the connective tissue disease category. Now, I'm sure someone listening to this is thinking, well, what about sarcoid? That doesn't fit into these categories. And it is true. The three buckets of this, of the three bucket framework that we've been working around does exclude some things. It excludes sarcoidosis, which, depending on what this rash looks like, might be a consideration, but Raynaud's is highly uncommon in that, so that's not jumping up on my list. This category excludes IgG4 and some of the more rare fascinomas, which I think are really satisfying to both Dr. Valle and myself. But I suspect we're going to be kind of in the connective tissue disease bucket, unless something additional comes to make us think more about vasculitis.
Awesome. I really loved your diagnostic laydown of all the connective tissue diseases. Yeah, that's really sound awesome. And Dr. Anna, over to you for the next report.
Okay, so we've reviewed most of her past medical history. Graves, which was ablated, and then afterwards she developed hypothyroidism. This was approximately 5 years ago. And approximately 2 years prior to her presentation, she was noted to have a left axillary enlarged lymph node, but it was biopsied and it was benign. The only medications she takes is levothyroxine, 150 micrograms daily. She does not have any known medical or drug allergies. She has had a surgery in the past. About 10 years ago, she had bariatric surgery, a gastric bypass. In terms of her social history, she is married with 2 children. She works at the local YMCA. She's a former smoker with a 30-pack year history, and she discontinued around, stopped smoking around 1992 when her first child was born. She does not take tobacco in any other forms, no other illicit substances, cannabis, or drug use. And in terms of family history, she has a maternal aunt with Sjogren's syndrome.
Dr. Annie, if you don't mind, would you like to give the vitals as well? Vitals, all the physical exam findings, so that we can
Yes, I
cover.
can move. Yes, I can move on to physical exam as well. Blood pressure is 113/66. Pulse is 95. And just to give you an idea, she's 5'3" and weighs 155 pounds. That's a BMI of 27.5. Generally, she looks well, no apparent distress. Her pupils are equal in size and reactive. The rest of the HENT exam is within normal limits as well. Her neck did not have any lymphadenopathy, and she did not have any axillary lymphadenopathy either. Her cardiovascular exam was unremarkable, regular rate and rhythm without murmurs, rubs, or gallops. And her pulmonary exam was also unremarkable, clear to auscultation bilaterally. Abdominal exam was also within normal limits, no tenderness to palpation, and it was not distended or rigid. And I will add, in terms of her neuro exam, her strength was 5 out of 5 in both her upper and lower extremities, and neck extensors and neck flexors. In terms of her musculoskeletal, or before we get to the musculoskeletal exam, I'll also do the skin findings as well. So on the left anterior shin, she had an area of 2 centimeter by 7 centimeter, non-blanching, very small pinpoint red almost papules that I would consider petechiae actually. So they were quite small. They were not palpable to the touch. She did not have any hair loss. She did not have any nail changes, any other bruising, telangiectasias, especially over her face, and no other nodules over her hands or over her elbows or in her toes either. Then lastly, with the musculoskeletal exam, and ready to go? Okay. So the musculoskeletal exam, she had a left wrist with a palpable effusion. It was warm to the touch, and it was tender to palpation. She had both. She had pain on both active and passive range of motion of that left wrist. And she, in her left hand, the PIP, and in her left hand, the 2nd, 3rd, 4th, and 5th MCPs were warm and had synovitis, as well as tenderness to palpation. Her left hand PIPs and DIPs were without warmth, without synovitis, and without tenderness, although she had a Heberden's node on her left 2nd digit DIP. The rest of the musculoskeletal exam, including the left elbow, left shoulder, right side as well, was completely within normal limits without warmth, tenderness, synovitis, and intact range of motion. I will add that her lower extremities, including her knees, hips, as well as ankles and toes, were also all without warmth, without tenderness to palpation, and without synovitis.
Yeah, Dr. Eli, now how do you approach? Now we have a significant family history of Sjogren's in the maternal aunt and a smoking history with 30 pack here. And then now how you're going to approach this scenario, and now how to narrow your differential, or what are the differentials we made? Yeah.
Yeah, so I think in residency, what I really try to learn to do is just slowly read the past medical history and slowly read the medication list, which is getting harder and harder because our patients are getting more and more complex. But I think it's so easy to just gloss over everything and move on. But if you read just every single line and say, could this be related to the chief complaint in any way? I think I've definitely missed stuff not doing that. But I look over this and I don't think anything in the past medical, meds, family, or social history really changes things dramatically. The family history is notable. She did have a swollen lymph node, but it's hard to know whether that was related or not. And that is also kind of a non-differentiating symptom of connective tissue diseases, the lymphadenopathy, which does have a significant smoking history, and it makes you wonder about perineoplastic phenomenon. But those are not super common with this type of presentation, so I'm going to put that on the back burner for now. The musculoskeletal exam confirms what we already thought. And I'll just point out that the MCPs, which are these joints here, are probably the rheumatologist's best friend. And that's because those joints are really not involved by osteoarthritis and tendinopathy, some of these other conditions that come up. So when someone has MCP symptoms, that really should make you think that this could be an inflammatory process, and that's the case here. I'm not seeing anything that raises suspicion for scleroderma, like sclerodactyly or puffy hands. I'm not seeing anything that raises suspicion for myositis, like muscle weakness or a skin rash that would be compatible. The petechiae are making me a little bit uncertain. They are not palpable purpura, so petechiae are much less specific, but they are certainly on a spectrum of when one might see a vasculitis. So I think we need to kind of consider the vasculitides as at least a possibility here, even though that's still not at the very top of my list. And I'm just dying, and I am reassured that she is satting well, and there's no evidence of interstitial lung disease as we think about what other organs might be involved for someone with what is typically a multi-system condition. So I'm just dying to see what the labs look like.
Awesome. Yeah. Now, whenever you see the patient in your clinic, and then you encounter all this physical exam, so what kinds of labs do you anticipate from the primary care physicians or internists to have labs on ready, and then what are the possible potential labs do you order, yeah, for the next steps?
Yeah, so I think typically we are really lucky to see people that have already had a lot of workup. So our job is so much easier in many ways. I think it can be much harder as a frontline physician, but certainly CBC, complete metabolic panel, and in a case like this, getting a urinalysis up front because a creatinine is not nearly as sensitive for intrinsic kidney injury that can happen in these diseases. Inflammatory markers, and I would suspect that most people would send an ANA. ANA is a great test because many of the more specific antibodies that I'm sure we will order in this case are captured in the ANA. So that if you have a negative ANA, it's almost impossible that they would have a positive double-stranded DNA or Smith. So in someone who is not kind of acutely ill and you have time, or if you're suspecting connective tissue disease, ordering an ANA alone is a very reasonable first step because it's a great screening test. But I'm sure other antibodies, which you can guide me as to when to talk about those, will be ordered.
Awesome. Over to you, Dr. Anna.
Okay, so I'll move on to the labs. So starting with her CBC, her white count is 4.6, which is within normal limits. RBCs are 3.78. Her hemoglobin is a little low, it's 11.2, with our normal being 12 to 14.5. And this is a normocytic anemia with a MCV of 92.6. And her platelets were 276, so within normal limits. I'll continue on to her CMP. Her sodium was within normal limits at 136, potassium as well, chloride as well, CO2 as well. BUN was 14, and creatinine was 0.82, both within normal limits. And she had an albumin that was slightly low at 3.4, and her total protein was elevated at 10.4. with our normal reference normally being 6.4 to 8.3. Her calcium was 8.9, that's within normal limits. Her alk phos was 52. Her total bili was less than 0.2, AST 30 and ALT 11 with anion gap of 9. So all of her CMP was within normal limits except for that elevated total protein. Then I can move on to the kind of specialty labs if we'd like. Or would you like to kind of specify which ones you'd like to get?
Dr. Eli, what do you prefer?
Oh, why don't we start with the ANA at least?
So the ANA was 1 to 2560 in a speckled pattern.
And maybe a urinalysis.
Urinalysis was completely within normal limits without protein, RBCs, or WBCs.
That is awesome. I so wish personally that instead of reflexing to all the specific antibodies, that an ANA would reflex to a urinalysis.
Yeah.
If positive, but obviously that's not practically possible.
Mm-hmm.
So I think the basic labs are not jumping out, and there's no sign of kind of internal organ involvement there. The high titer ANA supports what we already thought, that we are in the connective tissue disease category. And because both like lupus, scleroderma, and Sjogren's kind of remain on the differential, we want to take the step and order those specific labs. But I want to make the point that if this patient did not have Raynaud's, right, for example, we would really encourage people not to order scleroderma antibodies, right? Those are very specific antibodies, and because all antibodies have false positives, this sounds sort of simple, but it's harder to implement in practice, which is try not to order tests that don't line up with your clinical suspicion. Because if this patient did not have Raynaud's, a positive scleroderma test would mean nothing, would not be actionable, but would cause a lot of anxiety for the patient. But in this case, with the presence of Raynaud's, because that remains on the differential, we have to work those three things up. Now, I think what's not entirely clear to me is how much we should push on the vasculitis component with this petechial rash. In an ideal world, this is something we would biopsy, right? Because petechiae and purpura may be related. They also may not be because there are other preferred dermatoses that are kind of benign. So for the purposes of teaching, let's just put that on the side because I don't know if we'll have time or whether we want to get into the vasculitis discussion. But the next step would be getting the specific labs For lupus, double-stranded DNA, Smith complements and antiphospholipid antibodies. For Sjogren's, SSA and SSB. And for scleroderma, centromere, SCL70, and RNA polymerase 3. And one can certainly argue to do those in maybe a stepwise fashion. But practically speaking, I think in a case like this, it's reasonable to send what's on our current differential. And then finally, I'm sure people are saying, well, what about mixed connective tissue disease? And the reason I didn't bring it up as part of the connective tissue disease category is really because the easiest way to, it's a confusing condition. And the easiest way to think about it is that it's a combination of scleroderma, myositis, and lupus. And I think until you've made the diagnosis of one, it's not that helpful clinically to be actively thinking about whether it can be MCTD. There's not much going for it here. There's no sclerodactyly, there's no puffy hands, there's no myositis. But the RNP antibody is present in nearly half of patients with lupus. So we do order it, even when we're not highly suspicious of MCTD in a given patient.
Thank you, Dr.
Okay.
Eli. Yeah, I have one question. Apart from the serological autoimmune workup, so would you suggest, would you prefer any other imaging studies, like any CAT scan of the lungs and any abdomen, to look for any kind of paraneoplastic processes, and how you make a diagnostic decision to get the further imaging in this kind of patients?
Yeah, it's a great question. It depends on what we think the disease is. For example, someone with Sjogren's with no pulmonary symptoms, we probably wouldn't be imaging the lung, because even though ILD can happen in Sjogren's, it's not super common. But if this was scleroderma, where the prevalence of lung involvement is much more frequent, we would image it, right? And then the question of paraneoplastic syndromes is a really important one, and that also relates to which antibody is positive. There are certain antibodies that are more highly prevalent in patients with malignancy, and certain ones which are not. So I think at this point, we would, without symptoms of lung involvement, we would see what the antibodies look like first.
Awesome. Over to you, Dr. Anna. What do you have for us?
Okay, so we already reviewed her ANA. That reflexed into a row 52 of 84, with reference being 0 to 20, row 60 of 74, reference 0 to 20 again. Her SSB was 879, reference 0 to 20 as well. Double-stranded DNA was 0. Smith, RNP, ANCA, HLA-B27 testing, also negative as well. Centromere, SCL70, RNA polymerase 3, all negative as well. And an anti-cyclic citrullonated peptide, CCP, was negative as well. However, rheumatoid factor returned back greater than 650 with a reference range of 0 to 15. Her high sensitivity CRP, or C-reactive protein, was 1.9 within normal limits. However, her erythrocyte sedimentation rate was elevated at 44. Complement, so C3 was 122 within its reference range. C4, I apologize. Complement, C3 122 and then C4 22, both within their normal reference ranges. And to add thoroughness, and we were thinking about that rash a little bit more, we also obtained a lupus anticoagulant, beta-2 glycoprotein, and anticardiolipins, all three which were negative.
Awesome. So, Dr. Eli, how do you approach this ocean of serologists now to look for differentials?
So it's a lot of data to digest. And sometimes you get results back and it doesn't make any sense, and you have to go back to the drawing board. Fortunately, in this case, it really clarifies the picture, because your lupus labs are negative, your scleroderma labs are negative. The only other condition on our differential was Sjogren's, and the row and the law that are The LI is very specific for Sjogren's. Rho less so. Rho can be seen in lupus and Rho can be seen in myositis, but here it's just corroborates Sjogren's. The rheumatoid factor you might think might point to rheumatoid arthritis, but there are two labs that we test for when we suspect rheumatoid arthritis, which I'll just go back to our initial differential we were really not suspicious of at all. But the CCP antibody is very specific. The rheumatoid factor is much less specific, and we typically see it in other connective tissue diseases as well as other non-rheumatic conditions like hepatitis C infection. But of the connective tissue diseases, it is most prevalent in Sjogren's, including at high titer. So the labs kind of point to Sjogren's as the likely diagnosis here. So now if we kind of go back to this vasculitis question that's been hanging out, that I've been feeling a little bit uncomfortable with because the whole thing did not seem like it fits vasculitis. The vasculitides are tricky, but kind of the small vessel vasculitides are, probably the most common ones that we deal with. And then the large vessel one in adults is GCA. That's the other kind of big one, but this is not anywhere near that. So we would be thinking about small vessel vasculitides. They can be divided up in two categories, the ANCA vasculitides and the immune complex diseases. And in the immune complex diseases, there's cryoglobulinemia, which we'll return to. There's IgA vasculitis, which seems unlikely. But there's also what we call secondary vasculitis. And secondary vasculitis alludes to the possibility that another condition, specifically lupus or more commonly Sjogren's, has vasculitis as part of the clinical features. So if the petechiae are truly vasculitic, which now they really could be, it could be through two mechanisms, which is directly from Sjogren's syndrome itself, or through cryoglobulonemic vasculitis, even though there are no other features of cryoglobulonemic vasculitis here. But cryoglobulonemic vasculitis can be primary or secondary. And I think we typically think of the secondary causes like hepatitis C, but Sjogren's in particular, and less commonly other connective tissue diseases, are another cause. So I would be curious if we might be dealing with Sjogren's complicated by cryoglobulonemic vasculitis.
Her cryos were negative.
So that's a no.
Awesome. Yeah. So I really loved your discussion on these different serologies. Dr. Anna, what do you have for next?
And so I think together we've really kind of come towards the conclusion of the case here. She does have Sjogren's, and we have and with the help of our dermatology colleagues, after we saw the negative cryos, they helped us with a biopsy, and they did in fact think this was leukocytoclastic vasculitis in the setting of quite active Sjogren's. We did, after we found these labs and I saw her next, we actually began treatment with Plaquenil, and that significantly improved her joint pain. It did not improve her LCV, or the leukocytoclastic vasculitis, which she'll work on treatment with in addition to that with dermatology. But we did investigate for other kind of complications of her disease, which included an SPEP, which showed a polyclonal gammopathy, but it did not show an M spike. And we did end up obtaining a chest X-ray, which was abnormal, and we did in fact find that she had interstitial lung disease as well. So overall, this was a case, which of kind of more, which is more somewhat aggressive, active Sjogren's than I think we normally see or consider kind of in clinic. And so I thought it was really a really wonderful case that allowed us to talk about the three buckets of disease while also kind of giving us the ability to put it all together at different points of ambiguity, whether it was in the history, in the exam, or in the labs.
Incredible, Dr. Anna. Dr. Eli, do you have, further reflections on and I mean, what a journey it is. We started with the joint pain and I thought it was something related to rheumatoid arthritis and eventually landed up in Sjogren's and unfortunately the patient had complicated interstitial lung disease. And yeah, so what are your reflections and it would be great if you could summarize and share some of the clinical pearls we can take away from this session.
Yeah, well, first of all, what a great case. I think this is something that we see in the outpatient setting, right? This kind of complexity exists in the outpatient setting, and it's not just in the hospital. So if you want to deal with, sick people, this is something that, is definitely kind of common for us. And I loved how you picked something that touches on the breadth of what we see. I think there's kind of a couple of things that kind of jump out to me is that here is someone with kind of really debilitating systemic disease that I think will likely be able to help a great deal and will hopefully be able to live kind of a normal life, but likely on medication. It kind of highlights this phenomenon that I love about our field is that you get to be a little bit of an expert in other fields, right? So as rheumatologists, we know a lot about derm, we know a lot about interstitial lung disease, and sometimes it's really kind of gratifying when those specialists consult us for things that we could help with in their fields and vice versa. So kind of these close working relationships with other specialties. But I think this case is just a great case for the summary of what we talked about, right? How we started with, is this an inflammatory arthritis, osteoarthritis, or a fibromyalgia or neuropathy? And then we went to the three buckets of inflammatory arthritis, connective tissue disease, and vasculitis, with really the Raynaud's and the Sicca zeroing us in on the connective tissue disease bucket. The high titer ANA confirmed that we were on the right track. And then the more specific antibodies ultimately gave us the answer. And then this one piece that was hanging out here, could it be a vasculitis? Are we missing something? Actually fit. Because at the end of the day, I think at this point in my career, I don't spend as much of my brain power building a differential. When you've seen stuff again and again, that starts to come really naturally. And depending on which stage of training you're in, you're either experiencing that a little bit or you're already experiencing that a lot. And so I think a lot of our brain power is spent on dealing with, well, what doesn't fit? And since we very rarely have something textbook, I would say this is pretty good, pretty close. But oftentimes there is something that really doesn't fit, and you have to ask yourself, can I sleep with this? Is this explainable? Or do I need to rework my working diagnosis? And I think in this case, because the diagnosis was Sjogren's, where vasculitis is seen, where cutaneous vasculitis is seen in a minority, but not a tiny percentage of patients, we felt good about where we were at. Now, if this was scleroderma, for example, and the skin was vasculitis, well, that just wouldn't fit, and we need to think deeper.
Awesome, Dr. Eli, and thank you so much for sharing all the wonderful pearls. And Dr. Anna, and how does it feel like taking care of this patient? And it would be great if you could share some of your teaching points for the audience.
Certainly. So a lot of mine kind of overlap with Eli's teaching points. And it kind of encompasses why rheumatology is a great field, because it's really about fitting how all of these different findings fit together, kind of reassessing what if I anchor on the rash, what if I anchor on the joint pain, And sometimes kind of when you're at a loss, even thinking, what is the most specific kind of finding that I can, kind of I can find out of the myriad of different positive the Rubio systems. And so I fully agree with that's why I chose this case, because it touched on so many different aspects of how to not just, medical knowledge, but also how to really kind of investigate and piece that medical knowledge that we're talking about together. And I will say that it has been really rewarding to help this patient kind of live without joint pain. And even though we have found some secondary, we found the answers to her rash, and even though we did find some ILD present, the good news is that we found it and we're treating it before it's impacting her life. And so even though she has a systemic disease, we are able to really improve her quality of life and try to keep it as controlled as possible. And I think that's what, this is one of the things I love about rheumatology, not just how we put the cases together, but also that, most of our patients do well and we can have long lasting relationships with pretty good outcomes. Even when someone initially approaches you quite sick.
Incredible. I mean, glad the patient was getting better, and that patient is very, very lucky to have you, Dr. Anna.
Oh,
And yeah, thank you so much for sharing the virtual platform. And we really learned a lot from you, both of you today. And we are really expecting to learn more and more from you in the future sessions. Thank you so much. And I really want to thank Dr. Eli once again for sharing all the clinical pearls. And yeah, we really loved the session, Dr. Eli. And I really want to thank Vijay and Lira for doing the scribing and teaching points.
Thank you so much for having us.
thank
Thank
you
you.
again. This was wonderful.
Awesome. I hope you have a great rest of the day. Take care. Bye-bye.
Thank you. Take care.